So as most of you know, naloxone is an opioid antagonist. It has a stronger affinity to the opioid receptor than other opioids, such as heroin or oxycodone, so it knocks the opioids off the receptors for a short period of time. This allows the patient to regain their respiratory effort and reverse the overdose. It is very important to note, however, that the half-life is very short. On average, it lasts about 40 minutes, although the range is 30 to 90 minutes. So it's very important that these patients get to the emergency department so they can be further monitored. So when the naloxone wears off, it's possible they might go into respiratory depression again if they're using a long-acting opioid like methadone, for example. As per the product monograph for naloxone, the indication is reversal or partial reversal of opioid toxicity. In these kits, we would like a full reversal of opioid toxicity. The contraindications, the only one is known hypersensitivity to naloxone, which is very rare. There are a few side effects. The most obvious one is opioid withdrawal. This would include symptoms like nausea, vomiting, sweating, tachycardia, increased blood pressure, tremor, anxiety, tearing, and runny nose. Post-op, there have been some reports of hypo and hypertension, ventricular tachycardia and ventricular fibrillation, and pulmonary edema. However, in these cases, patients have been given too much opioids by the anesthesiologist, and then the naloxone is being used to reverse an iatrogenic opioid overdose. There also have been some reports of seizures. However, a causal relationship has not been established, and this is very, very infrequent. Storage is at 15 to 30 degrees Celsius, and product monograph does recommend that the naloxone be protected from light. So who is eligible for these kits? So luckily, the American Heart Association did publish in their recent guidelines some information for us to help guide us in this process. So on their table 1, they have recommended several groups that may benefit from opioid overdose response education and naloxone distribution training. I'll go through them one by one. So first, people who have used prescription opioids or heroin. I think this is the most obvious one. Anybody who uses opioids in any way is at risk for overdose, and they should get a naloxone kit. Second, patients who have required emergency care for opioid overdose. So this would be the case in Jake's presentation. So he has come to the emergency department treated for opioid overdose. We know that he is likely to overdose again, so why not intervene at this point and get him a kit so that somebody can save his life the next time it happens. Third, patients enrolled in opioid dependence treatment programs, including methadone and buprenorphine maintenance programs, particularly at high-risk periods such as induction or discharge. And I do tell all of my patients who I start on methadone or buprenorphine about naloxone kits and ask them to go and pick one up. They're at high risk for relapse during this induction phase, and we also know that this is the riskiest time for them to overdose. Fourth, persons with a history of opioid abuse or dependence who are being released from prison. Again, this is due to loss of tolerance, as I mentioned before. 5, patients receiving prescription opioid therapy with risk factors for adverse events. So anybody who is receiving opioid prescription therapy with benzodiazepines or other sedatives is at risk for overdose and should get an naloxone kit. Anybody who has ongoing alcohol use, and again, this is due to the respiratory depression. And 3, anybody who is on high-dose prescription opioid therapy. So this is really thinking a little bit outside of the harm reduction field and bringing naloxone kits into the world of clean clinics. So anybody who's in high-risk, high-dose prescription opioid therapy should have a kit. And finally, people living with or in frequent contact with those listed above. This is really important because it's not the drug user who's going to be able to inject themselves in naloxone. It has to be a friend or a family member or a bystander who will be able to inject the naloxone. The American Heart Association also published an algorithm advising us of how to take care of these patients who are at risk of death due to their opioid overdose. So I'm going to go through this step by step. Step number 1 is to assess and activate. So the AHA recommends checking to see if the patient is unresponsive and call for help. They advise that 911 is called immediately and that an AED is brought to the scene if there's one available. They advise that the patient should be assessed for any breathing, and if they are not breathing or only gasping for air, then CPR should be started immediately. CPR can also act as deep stimulation to somebody who is deeply sedated. The AHA then advises that naloxone be administered as soon as it is available at a dose of 0.4 milligrams intramuscularly or 2 2 milligrams intranasally, and this dose may be repeated after 4 minutes. If the patient responds, then they recommend continuing to stimulate and reassess the patient until emergency services arrive. And if the patient does not respond, they recommend continuing chest compressions and using an AED as soon as it is available. They do not make any mention of rescue breathing, as it has been removed from the basic life support recommendations of the AHA. I mentioned that naloxone is available worldwide, and really the first countries in England that started to distribute naloxone was England and Germany in 1995. In turn, Italy, naloxone is available over the counter, and in Scotland it's prescribed by nurses and pharmacists. In the States, there are over 200 programs, and the first program began in 1992 at the Chicago Recovery Alliance. It's been available in Canada through public health agencies for several years, and is now available in 7 provinces, including BC, Alberta, Ontario, Saskatchewan, Manitoba, Quebec, and Nova Scotia. The program first began in Ontario in 2011, and then Ottawa started distributing naloxone in 2012. Toronto Public Health has distributed over 3,000 kits and reports over 350 lives saved. So what's your role as a pharmacist in all of this? So really, you are an ideal point of access. We know from studies that 56.1% of people who died of an overdose filled a prescription for opioids in the month preceding their overdose. You can dispense naloxone, you can provide patient training, and you can keep a kit in case somebody overdoses in your pharmacy. So why would we bother? I would argue that we should be giving kits out to patients wherever they can get it, because we know that people often use together. We know naloxone is an effective antidote to reduce death. It's easily administered. I'll talk about that in a few slides, and you can save lives. The landscape for naloxone is changing rapidly in our country. So on March 22nd, 2006, Health Canada removed naloxone from the prescription drug list. So moving forward, patients do not require a prescription to get naloxone. Although naloxone was being distributed for free through public health agencies, it was under medical directive from the medical officer of health, and there technically was a prescription in each kit. However, if a patient ever wanted to get naloxone from a pharmacy, they would have needed a prescription. Due to the crisis of opioid-related deaths, it has been removed from the prescription drug list very recently. This doesn't mean that anybody can go to a pharmacy in Ontario right now and pick up naloxone. So the National Association of Pharmacy Regulatory Authorities, or NAPRA, needs to determine provincial drug scheduling. So naloxone still is a Schedule I drug in Ontario, and we're expected to hear from NAPRA in July 2016 about whether or not it will be moved to a Schedule II drug. In BC, the BC government and the BC College of Pharmacists have moved very quickly, and naloxone there is now a Schedule II drug, and that was effective March 24th, 2016. So anybody can go into a pharmacy now in BC and get a naloxone kit. Hopefully it will catch up in a few months. So what are we to do in the meantime? So there was a prescription order for the Ministry of Health on June 7, 2016. The prescription order stated that pharmacies that provide opioid agonist substitution treatment, so pharmacies that dispense methadone and Suboxone, and have a billing number under the OPDP, or the Ontario Public Drugs Program, are eligible to dispense naloxone kits free of charge. There is an online module available, and any pharmacy that distributes naloxone kits must complete the Ministry of Health Long-Term Care Online 2016 naloxone training module moving forward. The online module contains product information, overdose risk factors, how to respond to an overdose, what to expect after administration, follow-up, patient education, and documentation and reporting. Pharmacies will need to provide proof that they have completed this online training module. The Ministry of Health outlined the following responsibilities for the pharmacist. So first, pharmacists must maintain the standard of practice for Schedule II drugs. Pharmacists must assess patients for possible naloxone allergy before distributing a kit. Pharmacists must make sure they're adequately trained through the online module and various other resources. And pharmacists must also provide patient education. This really is the key point here. So the question comes up all the time in my emergency department: how come we can't simply put naloxone kits in a box at the front door beside our clean needles and allow patients to come in and take a kit as they need it? Well, the reason is we really have to train these patients properly. There is a CBSO policy on this. The College of Physicians and Surgeons of Ontario states that we can distribute naloxone, but we can only distribute to those who have received appropriate instruction in it. So patients need to be trained properly. We have to have the ability to identify and replace expired medication and inform patients of complications and risks of using naloxone. We need to enforce to patients that emergency care must always be sought in the event of an overdose, and 911 must always be called, and that all this information must be communicated in written instructions contained in the kits. So simply leaving a kit at the door isn't going to cut it. We need to teach people how to use it, how to use naloxone, how to recognize opioid overdose, and that it's so important that they call 911. The Ministry of Health has outlined 10 components that are required for patient education. So first is harm reduction. So this includes using safe needles, using with a friend, using a test dose, everything that we talked about earlier in the presentation.
All these signs of overdose: labored breathing, Cheyne-Stokes respiration, pinpoint pupils, meiosis, in a coma, cyanosis, that's blue pallor, all prove the heart's beating. It's not a cardiac arrest. It could be any respiratory emergency patient. They need air. Agonal gasping is not Cheyne-Stokes respiration.